Hi everyone, welcome back to another JJ Medicine lesson. This lesson is on giant cell arteritis. So we're going to talk about what this condition is, some of the risk factors and potential pathogenic mechanisms as to why it occurs. We'll also talk about the signs and symptoms, how it's diagnosed, and how it's treated. So giant cell arteritis is also known as temporal arteritis, arteritis cranialis, and Horton disease. So giant cell arteritis is a systemic inflammatory vasculitis. Vasculitis is a word meaning inflammation of a blood vessel, so it's often going to be systemic, meaning many blood vessels can be involved, but there is a particular characteristic proclivity of this condition to cause inflammation of the temporal artery. This is why we see the name temporal arteritis as a potential alternative name to this condition. So in this diagram here, we can see that this is the temporal artery. This is going to be the artery that is often characteristically involved in this condition. And then here's another image of the temporal artery on a superficial level. So giant cell arteritis is going to be considered a large vessel vasculitis. So it's going to be characterized as a vasculitis that affects large vessels. But having said that, it can affect small and medium vessels as well. We're going to talk about the different types of blood vessels that are affected in the next slide. And what's characteristic about giant cell arteritis is that it is caused by infiltration of multinucleated giant cells. This is why we have the name giant cell arteritis. So this condition primarily afflicts older patients, and the incidence of this condition increases after the age of 50. And the mean age of onset for giant cell arteritis is 75. This is actually the most common systemic vasculitis in adults, and it's associated with a condition known as polymyalgia rheumatica, which we're going to talk about as we go through this lesson as well, because there are important overlaps with these two conditions. And giant cell arteritis is actually estimated to affect anywhere from 5 to 30% of polymyalgia rheumatica patients. So it's quite important to recognize that there are some connections with these two conditions. So we'll talk about those as we go through this lesson as well. Now let's talk about the etiology and associated factors for getting giant cell arteritis. So the etiology of giant cell arteritis is actually unknown, but there are important associated factors that increase the risk of getting this condition. One of them is going to be increasing age. I mentioned this before. The incidence of this condition starts to increase after the age of 50. Being of female biological sex is also another risk factor, and it is estimated that there is a female to male ratio of 2 to 1. Genetics also seem to play a role in whether or not a patient is likely to get this condition. There is an association with HLA-DR4 haplotype and with regards to a polymorphism of the toll-like receptor 4 gene. And there is a higher incidence of giant cell arteritis in individuals of Northern European descent. And along with some of these characteristics, we can also see an important lifestyle factor that can increase the likelihood of having this condition, that is smoking. So a past history of smoking or being a current smoker increases the likelihood of having giant cell arteritis. And there is some hypothesis as to whether or not a prior or current infection can actually trigger this condition. Some of these can include the following: chlamydia pneumonia, mycoplasma pneumonia, parainfluenza, parvovirus B19, and varicella zoster. So these may be related or associated infections, but it's not entirely understood as to if these are simply associated infections or if they are actually triggers for someone that is susceptible to this condition actually getting giant cell arteritis. So just want to mention that here as well. Now let's talk about the blood vessels that can be involved in this condition. We mentioned that giant cell arteritis is categorized as a large vessel vasculitis, but we also mentioned that small and medium vessels can also be affected. So the small vessels that can be affected in this condition include the superficial temporal arteries. So this is where the superficial temporal arteries are located. We can also see the ophthalmic arteries being affected as well. These are going to supply the eyes. We can also see the occipital arteries being affected. This is where the occipital arteries are located. And we can also see vertebral arteries being affected and the posterior ciliary arteries being affected. So here is where the vertebral artery in this diagram here. Now with regards to the medium and large vessels, these are going to include the aorta. So the aorta is the large branch off the heart. We can also see the carotid arteries being affected. So here is the common carotid. We can also see the subclavian arteries being affected. So the subclavians are located here. And then the iliac arteries. The iliac arteries are going to be in the groin. So again, we can see a wide variety of different blood vessels being affected in this condition. And some of the most important ones are going to be these large and medium sized blood vessels, but some of the small vessels are going to be important in determining the signs and symptoms we can see. So we're going to talk about that as we go through this lesson as well. So now let's take a brief look at the pathogenesis behind this condition. If we were to actually look at a blood vessel and we were to actually look at the different layers of a blood vessel, the outside would be the adventitia, and we've got the media layer and the intima. Now, the pathophysiology of this condition is mediated by cell-mediated immunity. And there is some question as to whether or not the initiation of this cell-mediated immunity is started or triggered by endothelial injury. So endothelial injury would be injury to the inside of the blood vessel. This may be related to smoking. Smoking is an often important cause of endothelial injury. Whatever the trigger may be, what will happen is that monocytes, which are a type of immune cell, will be recruited to the adventitia. Then what will happen is that when the monocytes enter into the adventitia, they can be differentiated into other types of immune cells, including macrophages and giant cells. So again, these multinucleated giant cells are where the name giant cell arteritis comes from, and they're going to be the textbook characteristic finding in this condition. And all of these immune cells within the adventitia are going to cause inflammation. And you can imagine that if there's inflammation, there's going to be impingement of the blood vessel. There's going to be constriction of the blood vessel, and that's going to cause a lot of the signs and symptoms, which we're going to talk about here in a moment. So let's talk about those signs and symptoms now. So one of the signs and symptoms of this condition is a headache. So we talked about a lot of those blood vessels that are affected in this condition, and they supply the head. So you can imagine that if there's constriction or impingement of those blood vessels, we're going to have a headache, or there's going to be issues with head pain. Now, this is actually so common, in fact, that 75% or roughly 75% of giant cell arteritis patients will have a headache. This is actually going to be the most common initial symptom in 33% of cases. And what's important to take away here is that it is going to be a new type of headache in patients over the age of 50. Again, the incidence of this condition starts to increase after the age of 50. And then if a patient starts to have a new type of headache, a headache they've never had their whole life, then that's going to be a red flag for a potential issue. So any new headache that occurs after the age of 50 is often going to be a red flag. But in this case for giant cell arteritis, this is going to be what we want to look for. And again, the reason that we see a headache is that those temporal arteries and the occipital arteries are going to be constricted due to inflammation. And we can often see temporal and or occipital areas of the head being affected. So the occipital area is going to be the back of the head. The temporal area is going to be along the sides of the head. And the headache is often going to be described as throbbing or continuous in nature. And with regards to the temporal artery being affected, again, that's going to be a very characteristic artery that is affected in this condition. Tenderness to palpation over the superficial temporal artery may occur. So if you'd actually see the temporal artery on someone's head and you actually touch it, and if there's tenderness to palpation, if there's pain, then that can be a sign of this condition as well. Now, the headache itself may not occur in all patients, especially in those with isolated extracranial vessel involvement. So although we talk about this as going to be the number one clinical finding in this condition, it may not occur in all patients. If they have only blood vessels that are affected like the aorta or the subclavian arteries and not any in the head, that may also occur, so they wouldn't have a headache. So I just want to mention that here as well. Now, some other important signs and symptoms in this condition include neck pain, shoulder, torso, and hip pain. Now, for those that have a medical background, pain in these sites may trigger a thought of a particular condition, and that condition is polymyalgia rheumatica. This is the condition we talked about before that has a lot of overlap with giant cell arteritis. This is actually going to be the second most common initial symptom, in fact. So neck pain, shoulder, torso, and hip pain is actually going to be relatively common. It can occur as an initial symptom in 25% of patients. And as mentioned before, up to 30% of PMR patients can have giant cell arteritis. But if you have giant cell arteritis, up to 55% of GCA patients can have some of these polymyalgia rheumatica symptoms. So again, very important overlap here. Now, we can also see constitutional symptoms occurring in GCA as well. These can include malaise and fatigue. So malaise and fatigue can actually be an initial finding in 20% of patients, and this can be a relatively common finding that can occur in 50 to 60% of patients. And fever can also occur in GCA patients as well, which often affects an estimated 1/3 of patients, and weight loss can occur, but it's less common. Now, I just want to briefly segue here to talk about some of the connections between polymyalgia rheumatica and giant cell arteritis. There is question as to whether or not these are actually the same condition, whether or not one is simply on one side of the spectrum and the other is on another side of the spectrum. So I just want to mention that here again because as we've seen,